And so now with that, I turn it over to Edith, who will provide us more information about older adults. Edith.
Thank you so much, and good afternoon, everyone. Année, bonjour. I'm Edith, and I'm coming to you from Sault Ste. Marie, which is within the Robinson-Huron Treaty Territory. And I am honored to be here, to have been invited to share a little bit about the work that I do for our communities. I work for a North Shore Tribal Council community that services 7 First Nations along the North Shore of Lake Huron in Ontario. So I've been doing this work for a number of years. It started out as through funding from the LIN Aging at Home program, and looking at how do we ensure resources for our First Nation elders. And so with the funding, it was often joked that my title quickly turned into the aging coordinator, which I was obviously not too happy with. So we are evolving from that initial growth within our organization and building on our home and community supports within the 7 First Nations I work with. So it's been a long journey, and I have reached out to our elders in the community to help me with this job. They have been my guide throughout the enhancements to identify the gaps in services, the resources that are required. And so we've been together for a number of years, and coming together in the virtual form, I thought it would have been great to have joined you from one of our communities and with the elder at his sacred fire, which he offered. And sadly, Dr. Rastool mentioned the lack of connectivity in our community. So we didn't have internet there. So we're resorting to being more in the city to join today. But it does speak to the lack of resources within communities that we struggle with. So I say Chimigwech to Dr. Rastool for actually setting the context of what I would like to share and build upon around the lack of resources for home support services within our First Nation communities, and the work that we've done to try and enhance those resources. Some of the struggle that I have had over the years is trying to access external resources, bringing into community to support individuals in home. There has been some struggle around the funding envelopes, the assumptions from external partners on whose role is it to come into community to provide services. And these have been ongoing challenges that I've had with trying to introduce these services to communities, which our communities should be able to access. And sadly, that has not always been the case. So the work that I've done, and I shouldn't say the work that I've done, the work that we've done has been to build those bridges with those services. But quickly realizing that we have to rely upon each other within communities. We have to rely upon our resources and all of our providers, and to build that capacity to take care of our own. And I think that's come to light with the pandemic planning that we've done at the community level. I've been invited to sit at a local LIN planning table and quickly realized that the conversations there and the planning in place did not reflect the needs within our communities, or would not meet the needs in the event of an outbreak. So what we introduced was an additional structure with the inclusion of an Indigenous task team for the North Shore Tribal Council communities. And what we did is we brought together our First Nation health directors and community partners to start a local response to planning. And when we started the conversation, we knew that statements were being made that in the event of an outbreak in one of our communities, there would be resources from Health Canada the local providers would step in to assist. But what we realized as well is that we didn't know what that meant. So we wanted to really build upon our planning for a local response. And we have met every day from the onset, or every week from the onset of the pandemic, to start that planning at the community level, but also within our agency to look at how do we support, how do we begin planning, who do we invite to the table to help with this planning, so that what we put into place was reflective of our realities and what resources were available. So I'm so happy to say that we did get an amazing response from our local partners, the Public Health Unit, Indigenous Service Canada, Health Canada reps, our Ontario Health North reps, to assist us with that planning. And we identified 6 pillars to plan around, and recognizing that all of our escalation plans and processes would have to include our First Nation communities, as well as what resources were at the community level to support this planning. And again, it was more to realize that the response had to come from community. So I'm happy to say that we're still together as a task team every Monday morning. We come together to do that planning. But it's more of a reflection on how we've come together as communities to address our home care services, and really building upon that, that collaboration and building capacity in community as well. So I use this as an example of trying to ensure seniors are receiving services within their homes, and who is available to come to the table to ensure those resources are available. So I commented on the Senior Patient Advisory Council that was established to support that planning, and they were the ones to help guide that growth and identify the resources that are needed. We have a number of initiatives underway, including what does palliative care look like in our communities? What resources do we have to wrap around families and their loved ones when they want to pass at home, as opposed to in hospital or within long-term care? So that is an example of how we've realized that the answer is within the communities to do that. And we have maximized on the knowledge and the strengths within us to do that work, and just building upon that relationship that we have to look at other areas of needs. So really the current state, and within looking at the pandemic and how do we respond, we have realized that we have limited resources, but the collaboration at the community level has been amazing. And I'm always willing to share that approach that we've taken, not to say that we have it all figured out by any means, but I think we can all learn from one another. And that's really been my goal, is to share the work that we've done with other First Nations to assist in that, in those efforts. So I'm going to stop there. If you have any questions, please feel free to reach out to me, and I look forward to continue sharing the work. Miigwech.
Thank you so much, Edith. I will ask Laura to please unmute and go ahead, and looking forward to Q&A with all of you.
Thanks very much for having me. So when we're looking at the question of how are older people faring in the time of COVID-19, it's really hard not to get caught up in the long-term care question. And I know that my colleague Jane Meadus, who is on the call, will be speaking about the issue of long-term care in particular. So I'm going to leave our conversations about long-term care to Jane. And so what I thought that I would speak about a little bit more today is talking about how older adults have experienced social isolation and elder abuse in the time of COVID-19. And I just wanted to give you a little bit of a context of, where we were before and what COVID-19 has done, during the time that we've been really isolated in our own homes. So I propose to just kind of talk in my session about kind of where we were and where we are and what it's looking like that we're going to be going to from here. So I also just wanted to start off by giving just a very, very brief overview of the work of Canada's advocacy organization, which is my organization, CanAge. And during the time of COVID-19, we decided that the most effective thing that we could be doing to support older people was both answering the phones, and we certainly had hundreds and hundreds of seniors and family members reach out to us, and we tried to help and support and navigate them, but also to address the significant gap that we have in Canada around not having a plan for aging. And so Canada has been unique in OECD countries, and not in a good way, by not by essentially being the only country without a plan for aging. And so over the course of about 5 months, we did sort of thousands and thousands of hours of work consulting across the country in every jurisdiction with all political parties, working to crunch the numbers from key stakeholder organizations to review the myriad commissions and inquiries that we've had in the space of older people. And over that process, we came up with 6 compass points, and they are what you see here: violence and abuse prevention, optimal health and wellness, infection prevention and disaster response, caregiving, long-term care, home care and housing resources, economic security, and social inclusion. So I'm just going to touch on the points particularly around V and S, our violence and abuse prevention and social inclusion. So we're always trying to ask this question from a problem-solving perspective. So CanAge is very much focused on trying to move things forward and sort of make things better. But it is helpful to frame it within the context of age inclusivity. So in our roadmap for Canada's seniors, we again had 6 compass points, which you've seen, 40 issues across the VOICES compass points. And you can see issues 1 through 5 are here. And then if you go online onto our website or download the PDF, you will see that under each of those issues are a series of very specific policy recommendations that speak to the experiences both pre-COVID and during COVID-19. And so we have, again, 6, 40, and 135 very specific recommendations. So what was happening prior to COVID-19 in abuse and neglect, and then what's been happening since? About 1 in 10 older people will admit to having been abused and neglected pre-COVID-19. And like other forms of abuse, certainly we know that it's underreported. In 2015, we did a large community prevalence study called Into the Light, and I was part of that research team that looked at abuse and neglect in a number of different perspectives. So it looked at it from a financial perspective, emotional and psychological issues. It looked at it from physical abuse, institutional abuse, and that's certainly one that I know my colleague will speak about. And then also looked at it from the perspective of sexual abuse and neglect. It's important to remember that that study was limited only to members of the community. So it was not in an institutional setting. So it does not capture really that the experiences of people who live in long-term care. And it only was a response system for people who were themselves mentally capable of answering. So we know one of the big predictors of social vulnerability or abuse is whether or not you have cognitive impairment or not. So it's a limited study. And even within that, it's about 1 in 10. Well, we actually believe, if you crunch the numbers in a number of different ways, we get to about 1 in 5 or 1 in 6 people will experience abuse and neglect. So it's a lot as an older person in Canada. We don't have capital E evidence. And when I say capital E, I mean it's the kind that you would hold up to a sort of scientific review, because the time of COVID-19 is still ongoing and numbers are expanding in contraction. But I can share with you some early information and early data that we have, which has been shared with the Senate and shared with provincial and federal governments in other ways, and certainly is a real challenge right now. Give you one example, and I'll just give you the Ontario example, but I'm happy to talk about other provinces and territories as well. During the time of COVID-19, we have seen a stark increase in 2 types of abuse and neglect in particular that we know about. Again, it's a hidden issue. One is, it's been a rise in financial abuse. In some cases, we've seen, massive spikes, particularly in frauds and scams, often directly related to COVID-19, like actual COVID-19 benefit frauds and scams, or focused specifically on COVID-19 and money. We've also seen a significant rise in physical abuse, it appears. And so, we understand that often within the context of either people who are now locked up with their abusers, with people who were not able to go into the community in the way that they would ordinarily go to get resources and supports. The bridge games aren't happening. The walking club isn't continuing. And some of the, religious or faith-based organizations, which often provide some needed supports to some members of the community, are closed. So we're seeing that people are kind of locked up with their abusers and without those regular outlets. We're also seeing folks move home. And if we think about kind of the portrait of the abuse, about 2/3 of all elder abuse and neglect is perpetrated by those closest. So, caregivers, friends, and families are the overwhelming folks who are perpetrating elder abuse and neglect. That is now only offset by financial because of the stark increase in financial abuse. So it's not that there's less of the others, it's that there's more financial. And now it's about 50-50 stranger abuse and neglect for financial as it is for in-person. We've also been surveying across the country in terms of looking at both the response-based organizations and police organizations. And what we've seen, again, anecdotally here, doesn't live up to capital E evidence, but it is certainly persuasive, is that there's been a huge increase to resources for community-based organizations. So in BC, it might be, Seniors First BC or the Sail Line. In Ontario, you're looking at the Ontario Elder Abuse Prevention Ontario organization and similar. So giving you an example, there's been on average about a 10-fold increase in reporting to community-based organizations by seniors of abuse and neglect during COVID-19. But there has been a reduction, it appears, through early information and reporting to police. So people are more trying to reach out to community-based organizations and feel less comfortable having police involved. And that's a very interesting outlook. And it looks like, people are feeling less safe. Certainly leading off into our conversation, we are also very, I think, scarred by the stark realities of the types of institutional abuse and neglect that we have seen during the time of COVID-19. And certainly the military whistleblower report will never again kind of let us think about long-term care in the way that we did before. And it's important to know that many long-term care homes have done as great a job as they possibly can, and that there's wonderful long-term care homes, but there have been some where the outcomes have been horrific. And I just want to conclude the last couple of minutes by talking about social inclusion. So elder abuse and neglect and social inclusion are certainly related to each other. And we have seen a sharp increase in loneliness and exclusion from community based folks as well as those in long-term care. So again, my colleague will speak more about long-term care. So I just wanted to share with you that, our issues that we included here that you can see are around things like loneliness, seniors and technology, transportation, ageism, Indigenous seniors issues, and intergenerational issues, all of which speak to that notion of social inclusion. One of my very first comments when we heard, in this case, it was the Ontario Premier, Doug Ford, say that he was going to put an iron ring around seniors. And then the next thing I heard was Dr. Theresa Tam talking about all people over the age of 70 should self-isolate. And I thought to myself, I wonder how the boomers are going to do with this, because for many people, recently 70 or above, they wouldn't necessarily consider themselves older people, and they may have never considered themselves as being vulnerable. And yet now there's this new narrative that because of COVID-19, they have increased vulnerability. Layer that onto people with pre-existing health conditions, the folks we're talking about, at this session right now, you have increased worry and increased isolation from broader community and existing supports. And we heard that with my colleague who was talking about how they had to pivot from the then named Schizophrenia Society, and even my colleague who just preceded me talking about community-based resources. We've needed another way of function, and that's been a real challenge as we've gone forward. So just to wrap, what can we do and where are we right now? The Voices of Canada Seniors is available for download, and it's also available in various accessible formats on our website. I've put some resources here, and again, happy to share the slides as well, of our organization and the Canadian Network for the Prevention of Elder Abuse, which is a great organization to go and it will help to locate you into other areas. And also the Canadian Centre for Elder Law has got lots more information on some of these issues. I would love to invite you to check out our resources and tell us your story. So one of the most important things that we do is collect stories, and we will have one of our trained team members, many of whom are actual trained social workers, reach out to you or any colleagues you have and walk through our process, whether or not you'd like help and support navigation. We try to assist as much as we can one-on-one. But if you have a story to tell, we will collect that and then work with you to see if you want to disclose names or not names, and so on and so forth, because we try to make sure that we bring the voices of Canada's seniors and caregivers and supporters into all of the work that we do. Got a lot of recordings and webinars and YouTubes and every other kind of great thing as well. So I just wanted to close by offering those resources to you. So again, what have we seen in some? We've seen a sharp rise in abuse and neglect, a sharp rise in social isolation. And unlike many other issues that have had addressed in the violence, for instance, against women, and violence against Indigenous people and violence against children, have now had something like $743 million given to it cumulatively since the time of COVID-19. And there's been precisely $0 given to abuse and neglect, absolutely zero money being given to abuse and neglect on the issue. So we see a stark differential impact when we're looking at violence of older adults. Thanks very much. Happy and to enjoy our conversations together. And I know that my colleague Jane is now on the call as well.
Laura, thank you so very much. And Edith, we again gave us a lot to think about, and I have good news and not so great news. So the great news is that Jane was actually able to join us, like Laura said. So thank you, Jane, and sorry about the tech issues. The not so good news is that we're going to shorten our break a little bit and ask that we go on break now and everybody comes back at 1:35 for our next panel, which we'll proceed with as scheduled, and then ask Jane to please present before we go into Q&A altogether, just so that we're respecting the timing of the panelists for the last panel of the day. So I ask everyone, please come back after this scheduled break for 1:35 promptly. And of course, this is a scheduled break, but we welcome you to take breaks as needed throughout the entire session. So thanks everyone very much again. I'm looking forward to meeting you back here for our Q&A session.
Home is where the heart is. You hear that saying all the time. That's the base of a good, healthy living.
And one of the key differences between us and the mainstream programs is that reconnection to community. And that's what's really helping us. Our cultural worker and the program that she does helps bring people back to the fire.
We recognized before we even set up shop and started to serve people that it was really about taking them from the community that they're living in and creating community around them.
We often talk about, it takes a village to raise a child. Well, I think it takes a city to bring someone home.
I love it.
In 2011, we released a report called Our Health Counts, and that started the relationship with the city and discussing the homelessness of Indigenous people in Hamilton.
We did an Indigenous-focused point-in-time count where we had a magnet event, and we came up with over 43% of the people who we interviewed were experiencing homelessness that were Indigenous. And we're sitting extremely high compared to our 3% Indigenous population.
There is a housing crisis going on, and it's much more far-reaching than just Hamilton.
So when the opportunity arose to find homes for people where we didn't judge whether or not they had an addiction or a mental health problem, but we just wanted to help them, to save them from having to sleep on a cold street at night, it was a no-brainer.
The way that it used to be done is that you couldn't get into housing through a program until you started taking care of your addictions and stuff. But they found out that it's not possible for people, which is why housing first is the new best practice.
Yeah, absolutely. Immediate access to housing with no readiness requirements, with a recovery orientation. It's the only way to get people to be in a spot where they can look at recovery, is to get them into housing first.
And we never say you're not housing ready. We'll house you, and then we'll work on your other problems and your issues.
I worked at the same job for 17 years, and one day I just couldn't get out of bed. I just had no energy, and I thought, I just can't make it, I'm sick. After I lost the house and the wife and the kids, and, all I had was like a sheet and stuff that that I moved with, 'cause I moved with a cart.
Housing ties into all things health-related. Somebody is unable to have a safe place to keep their medication if they don't have housing, which means it'll be stolen from them, it can get lost. Or if they need a health card, you have to have an address.
Well, I lost my house, and I had heirlooms and stuff that I kept with me. And I got, all my income tax papers, all my birth certificate, this with my health card problem. They threw everything out of my really personal things, my Bible, things like that. They tossed it like it was yesterday's garbage.
When you don't have housing, the barriers to stack and stack and stack to the point where you don't feel like you can overcome them.
I don't know, I just became someone else after.
So Rick was homeless really on and off for about 10 years, and he was very sick when he first was presented to Homeward Bound.
When I got here, I weighed probably 118 pounds. I was pale, I had pneumonia.
There was some COPD that was quite serious and undiagnosed. And, just that social disconnect, from family and friends.
I happened to come here, and they welcomed me with open arms. Anything they can to be on your side, to make you relax, to make you feel secure. See me for who I am and not what happened. It gave me confidence again, that I'd lost.
It was his birthday soon after he came into the program, and we got him a cake and we sang to him and had a bit of a party. And he said that hadn't happened for 10 years, and that's a couple of years ago now. And there's a very big difference in the Rick that we see today than the Rick that we saw 2 years ago.
A lot of our clients have a lot of barriers that they have to face, whether it's bad credit, no identification, no bank account, having mental issues, having addiction issues, and they have so many barriers put in front of them.
I was a chef. Yeah. I want to go back, but yeah, it's my reserve, and these grades are so full, And what happened to my wife in Wiki? These drugs, and she was 25 when she passed away.
When I first met with Dwayne, I actually met him at the health center, and he was pretty aggressive at the time, but it turned out that he has an acquired brain injury. I actually went to high school with him, and he is not the same person that I knew back then, unfortunately. He's had a hard run at life, and I'm glad that I was able to help him, though, because a lot of people didn't want to deal with him at the time.
Oh, I'm happy here. Got this apartment. Yeah, I got this furniture here. I love it.
He needed a little bit of extra attention, It wasn't just me that did it, it was the whole team that did it.
We feel blessed to be a part of our team because Homeward Bound is a little bit different than sort of mainstream Housing First models. For instance, you're not supposed to have healthcare on your team in Housing First. We have a nurse practitioner capable of doing assessments. She goes to people's houses. She's able to prescribe medication, and she makes those connections to get people to see doctors, to see specialists.
And we provide a supportive program for 2 years, actually, which is very significant and I think very important because, you know, you can house someone, but actually sustaining that housing is a more difficult job. And I think it's because of our support and that we're there and we have regular follow-up and we check in very frequently. I think that has been the key to the success, for sure.
We've actually housed 193 people. That's as of March 2018, but we've worked with over 249 individuals just to get them to that point of even housing readiness. There's a multiple of different issues or barriers that one faces, and once somebody is housed, that's not eliminating all of those issues, right? So, and sometimes that's when a lot of that stuff comes to the forefront, because even though it's a
Hello, everyone, and it's my pleasure to welcome you back. Thank you again for your flexibility with our shortened schedule break time. And again, that's just what we had scheduled, so please take breaks as needed. It is my pleasure to get us started on our final panel for today, again, before we break out into Q&A. And before I do, I just want to remind you, if you have questions, please do jot them down in the Q&A box, and we'll do our best to get to all of them with all of our speakers together. So it is my pleasure and gratitude that I introduce our next panelists for our panel that is looking at income insecurity today. I welcome Angela Robertson, Executive Director of Parkdale Queen West Community Health Center, followed by Tracy Smith-Carrier, Associate Professor, School of Social Work, King's University College at Western University. Thank you again to you both, and I turn it over to you, Angela.
Hello there. So thank you for the opportunity to be part of this conversation. And in speaking about income insecurity, the lens that I want to take to this conversation is bringing an equity and an intersectional lens to how we have the conversation and how we think about income insecurity, and in the context of patients and redefining the future of healthcare is how do we think about income insecurity with an intersectional lens. So I think it is important to acknowledge, and the thing that I think we know, but important I think in this context to just keep repeating that we know that our health is deeply intertwined with our economic status, and both health and economic status are heavily influenced by social factors that are beyond the individual control. So when we talk about income insecurity and health, is that we're talking about system, and therefore the need for systemic changes to ameliorate and address these sites of disparities. And that as well, we need to think about the broader social determinants of health. So when we think about income insecurity, we also need to think about the interconnections with issues of race, issues of ethnicity, issues of indigenous identity, issues of gender identity, immigration status, and the rural-urban divide. So we cannot afford to think of solutions in a single strand because of the interconnected nature. I want to kind of frame a little bit when we think about income insecurity, the present moment that we're in. So we are in this present moment of COVID-19, a pandemic. And what we have seen with COVID-19 is the impact. We have seen the impact and the differential impact of COVID-19 on a range of communities and populations. So in this city in Toronto, where I am, we have seen that 79% of reported COVID-19 cases where racialized ethno-racial data was collected, we have seen that where ethno-racial data was connected, that 79% of the individuals who have been impacted come from racialized populations. And that really, this represents a 3.4 times the ratio of white populations here in the city in terms of COVID-19. And that of that, 72% of those who have been hospitalized have been racialized. And additionally, that we have seen the acuity in positivity rates among populations where low-income people live and reside, and where low-income people live and reside is also correlated with the presence of a high ratio of racialized individuals. I start there because I want to draw our attention to the fact that conditions that existed pre-COVID, so the disparities around income, the disparities around gaps in social determinants of health that existed pre-COVID was the stage setting for the differential impact that a pandemic like COVID will have and is having on populations and communities. So when we think about income disparity, no, we also need to think about how continuing to have these rates of disparities can become real fertile ground for exacerbating detrimental impact and consequences for populations moving forward when an issue like COVID-19 presents itself. And I think as well that we then overlay, we're in the moment of thinking about the coming of vaccine. And therefore, when we take an equity and an equity lens to the ethical conversation about who gets vaccines first, we also need to bring an equity lens that also look at who are the populations that are differentially impacted. So just feeling that as we have this conversation in this moment that we need to think about that. I won't go on at length about where the sites of inequalities exist in terms of income disparity, but I would signal that women still earn 78 cents on average for every male dollar earned. So we know that there continues to be a persistent disparity in that is gender-based in terms of income. And that when we look within the category of women is that we see still a differentiated in terms of disparity, where you have racialized women, indigenous women earning less than their white counterparts. So even within the gender categories where we see income disparity is that their differentiated impact. One of the things that we know is that folks who are poor have poorer health outcomes. And they have poorer health outcomes because they have less access to good jobs, and good jobs we know come with things like benefits, and we know things like benefits comes with enabling access to good and quality health care. The other thing that we know is that folks who are poorer have a lower life expectancy. So we know that women who are poorer die earlier than folks than women who are richer. Likewise for men as well. So we know that there is not just a theoretical in terms of perspective around these differentiated impacts, but there's a practical, tangible, and detrimental impact for these sites of disparities. Some of the things that I think we also know is that folks who are poorer, when we look at cancer screening rates, is that they have lower cancer screening rates than their rich counterparts. And what that means is that if you have a lower screening rate because you're in the low income quintile, is therefore when you finally get screened and a cancer is detected, is the likelihood is that your detection is at a later stage, which then leads to a higher mortality rate for low-income communities. The other piece that I think it's also important to note, and I know that in the previous panel, there was, the focus on mental health, is that half of in terms of poorer individuals report poorer mental health, but also folks who are low income show up in emergency as their first point of contact to access mental health services and support. And we know that folks who are racialized, particularly folks who are Black, show up for mental health support through the justice system. So usually because there's a police intervention. So we know then the differential implications for low-income folks around mental health services and mental health impact, but then also racialized folks and where that entry for racialized folks and specifically Black folks in terms of accessing service. So when I think about and when I suggest to you that as we think about income insecurity, we need to think about the points of, we need to think about differential impact, and we need to think about intersectionality, and intersectionality being the various convergences of our identities that can produce different sites, different experience of inequality, but also magnify that inequality differently based on race, gender, sexual orientation, disability. We heard earlier in the earlier presentations around the differentiated impact for people with disabilities. And we know that people with disabilities have a higher a higher distance in terms of workforce participation because of discrimination, in terms of hiring folks with disability, and therefore higher rates of poverty. So when we think about intersectionality, we need to, as I said earlier, we need to look at all of the sites of inequalities that folks experience and therefore map strategies that seeks to ameliorate those sites of inequalities and bring an intersectional lens to those sites of inequalities. And when we bring that intersectional lens in the context that we're in this moment, it's important for us to talk about the impact of race and racism. So the impact of being racialized and the impact of racism and the impact of anti-Black racism and anti-Indigenous racism. Because we're in a moment particularly where we have seen that magnified by COVID, and we are in this, land of Canada, whereby we are very much subscribing to the notion of multiculturalism, and the notion of multiculturalism has really muted, I think, our ability to name racism, to name race and to name racism as determining factors for health. And I think this moment allows us to make that call. And we just saw what happened with our sister, Joyce Echequan, the Indigenous sister in the Ottawa Hospital, and what happened there as a current example. So this is not historic issues. These are present day realities that we must contend with. So when I think about what are some of the changes that and sites of changes that I think we need to lift up to address the inequalities that are magnified by income disparity, is I think about two strands. I think about the policy changes and I think about the basic needs, tangible changes. So my position would be that social policy is health policy. And therefore, the social policy and policies that I would recommend that we think about in our various networks advocating for is an increase to minimum wage. We saw in Ontario that that was on the books and new government change, and that was receded. That we need to have a good job strategy, and that these two pieces need to be twinned with the strategies that governments are lifting up as part of their pandemic recovery plan. Because pandemic recovery plan cannot be a return to pre-pandemic conditions for many of the populations that we are talking about, that when we say low income. And therefore, this moment, I think, also calls for some policy changes with regards to protection for essential workers. So when we think about income disparities, and who are the essential workers, is the essential workers are largely low wage earners. They are workers who are in precarious employment without benefits. And this is a moment that calls for some advocacy to correct that. Another social policy that I would say it's important for us to think about advancing is social assistance rates that are indexed to cost of living. So right now, if you're in Ontario, your social assistance rate is about $580 plus for a single individual. And we know that housing for a single individual is over $1,200 a month. And that's called affordable. And therefore, this flips me to, in this moment of that we need to think about one of the solutions around ameliorating and addressing sites of inequality around income disparity is a focus on rent geared to income strategies and affordable housing strategies. I'm sure others have talked about national farmer care, and in terms of the Brenda earlier in the first, I think, panel in this series, as an Indigenous sister, I think we need to think about and push for the full implementation of the Truth and Reconciliation recommendations, as well as the Missing, Murdered, and Indigenous Women's report recommendations. Currently, we're in the middle of a national childcare plan. We have seen with COVID that women have been dislocated from the workforce, but we know that it is not all women who have been dislocated from the workforce, that essential workers who are largely racialized are still very much participating in the workforce, but without the childcare supports needed. So a national childcare strategy is one. And then lastly, I would suggest that as somebody within the healthcare setting is we need to think about how do we integrate what is now called social prescribing, social medicine, social care in how we deliver healthcare services that really integrates a broader determinants of health lens that can look to what are the differential supports that low-income patients will need as part of the prescription needed for them for better health. And I will lastly just comment on, as I know we're going to be heading into breakout rooms and talking about what are some of the tangible ways in which patient and patient networks can begin to plan and convene, is I think patient networks also need to think about different strategies around how to engage low-income patients. So we need to take a population lens and a population engagement lens to how we engage different populations, because just having a patient advisory does not mean that Angela, who is an essential worker working various odd hours, can have room to participate in those kinds of structures. And therefore we need to lift up different kinds of strategies to engage low-income communities who are pressed up against not having time for meaningful participation and co-creation in some of the strategies that we have been talking about. So I will halt there and look forward to the conversations.
Thank you so much, Angela. I think that was a fantastic presentation, and you brought together so much of what we've already been talking about today, so thank you. And I'm grateful to turn it over to Tracy for the next portion, who's going to focus a little more on the rural perspective too, so it'll be a great perspective to add here. Thanks, Tracy.
Thank you for your kind introduction. Yes, so I'm discussing rural poverty, and this is based on a literature review and community feedback from consultations that happened across rural communities in Ontario. So there you have the link there if you're interested in accessing the report. So these are some of the themes that came out of those consultations in the literature review, and we'll follow it up with the recommendations and action items at the end. So I know it's a bit of a whirlwind, but bear with me. I guess I want to first start with just a scenario. A mother sitting at a home, scared in case her husband gets home early and food is not yet on the table. There isn't a lot in the fridge except a few condiments. The house is drafty and cold, needing major repairs. The kids haven't come home from school yet. She feels depressed and overwhelmed. The internet is spotty and there's no one she feels she can call. This is an all too common story for rural residents today. Well, in urban centers, we've seen quite a bit of growth over the years. The areas of rural and remote Ontario and the rest of Canada have seen increasing outmigration, population stagnation, or limited growth in many areas. Rural residents accounted for 57% of Ontario's population in 1901, and this has declined all the way to 14% in 2011. These areas are not homogeneous. They reflect diverse community profiles. Some are associated with monolithic whiteness, although rural residents can present multiple identities based on gender, class, race, and so on. Stats Canada defines a rural area as a population of under 1,000 people. We know that poverty is a multidimensional concept linked to multiple determinants and consequences. There's no specific definition of rural poverty relative to urban, although there's an increasing acknowledgement that we can define poverty in a narrow sense or in a broad way. So the narrow looking specifically at a lack of financial resources to meet one's needs, and a broader one that acknowledges both material deprivation as well as the social deprivation that people living in poverty experience. It's also important to note that employment alone does not guarantee a life free from poverty in rural or in urban areas, and that there are many people and individuals and families that are working, often at multiple jobs, trying to make ends meet. Community attachment leads to positive health outcomes and mental health outcomes. It reduces stress, depression, and lowers our risk of mortality. It also improves self-esteem, increases levels of civic engagement, volunteerism, and participation. So those with close social ties have higher rates of self-reported health. COVID-19 obviously is challenging the benefits of these social ties. And we know that social isolation kills. Many poor health outcomes are linked to social isolation and loneliness. So people living in poverty, older adults, like we've heard, those geographically isolated or owing to cultural expectations or language barriers are often the most at risk for isolation. Rural Canadians with low incomes often sacrifice necessities like food and clothing to afford broadband service, and spend a greater share of their income on it than the average Canadian household. Although Bell accelerated its rural internet rollout in response to COVID-19, particularly trying to ensure that, that kids in schools were able to go online during the lockdown, many communities and individuals still do not have access to high-speed internet or have spotty provision. There remains challenges related to the limited nature or fundamental lack of public transportation systems in rural areas. And we know that many people prior to COVID were making exceptionally long daily commutes to and from work. And so that transportation has often been through personal vehicle, so access or ownership of a personal vehicle, with very few or no local buses or infrequent or intermittent schedules of bus networks or transportation networks. Those unable to afford or access transportation face barriers accessing programs and services, and often those with mental health challenges must move to urban corridors to access appropriate services, leaving behind their existing social support networks. So speaking about the access to services, there's a gross underservicing of services in some communities. The social and economic restructuring that happened from 1998 to about 2005 involved the application of urban and market-based models of efficiency that led to many closures or the reduction of services. So this call to streamlined efficiency meant significant regional consolidation, meaning that services were only offered at the regional level. Oftentimes, these were at great distance away from local residents. So we also saw the retrenchment in health and social care sectors, meaning cutbacks in access to basic education, protection services, and less access to civic administrative offices or governmental services.
Hi, Tracy. Sorry, it's Leah stepping in, just asking you to, I know you have a lot of fantastic content. If you could try to get through, it would be appreciated. Thanks.
Absolutely. Just speaking about employment, there's obviously employment has been affected. You know, before COVID, we saw a lot of dwindling of the manufacturing and natural resources, some of those sectors, farming, agricultural, affected before. Those communities that are heavily reliant on tourism, for example, are even more in dire straits as a result of COVID. Formerly, intimate partner violence was believed to be pretty much comparable across urban and rural areas, but now we're starting to see research that indicates that it's higher in rural areas. This could clearly be because there are fewer options for women in rural settings to leave their abusive partners. And as we've already discussed, COVID-19 is compounding the isolation and the barriers that women in these communities are facing. We know that rural households relative to urban ones have lower incomes and can persistently report low income status and higher unemployment. Though the experiences of poverty might be similar across urban and rural areas, the experience of poverty is unique in those rural settings where the services and programs are often lacking. Actually, we have some research that indicates that food insecurity is actually higher in urban areas than in rural settings, although we know that, that food insecurity in the north is particularly dire with an upwards trend over the last few years. The problem of homelessness has largely been overlooked, actually, and underestimated in rural areas. There has been a tendency to focus on home ownership rather than rentals in these areas, and that there are a number of people living in outdoors in tents, RVs, cars, or in buildings that are not really fit for human habitation. Although a lot of people in the hidden homeless population wouldn't actually define themselves as such and are unlikely to access services as a result. I'm going to skip over this slide just because we've already discussed, we've had some of our panelists already discuss some of the issues that Northern and Indigenous communities are experiencing. In terms of health outcomes, access to health, we know, again, we've talked about the social determinants of health as being greater risk factors than those associated with, traditionally defined public health measures, poor diet, tobacco use, low activity levels. Although we know in health, there's shortages across the board, across the continuum of care, shortages of primary care workers and specialists, overstretched care providers, lengthy wait lists, confidentiality concerns sometimes in the community, and the lack of culturally and linguistically appropriate services. Right now, under the context of COVID, the focus is really on expanding virtual services, and of course, these present their own set of challenges. In terms of mental health and addictions, we don't have a lot of literature actually on mental health and addictions in rural areas. We do know that there's a lot of barriers in relation to infrastructure, Shelters, mental health access points and crisis services are often lacking. People finding it difficult to access services because of transportation, because of those long wait times that we've discussed. So obviously having access to crisis beds and crisis mobile teams would be helpful, although again, we don't have a lot of literature or research that really has evaluated these in rural settings. This obviously will be necessary, particularly in the context of COVID-19, where we have such a focus on virtual mental health care. So in terms of recommendations that came out of that report, first of all, ensuring that everybody has access to a basic income for all Ontarians across Canada, in terms of especially the working age population, enlarging transportation networks in rural remote settings, encouraging job creation, access to mobile medical and mental health services, building community hubs and networks, and really trying to develop a research network to examine rural trends, because we really don't know that much. So much is focused on the urban setting. Addressing housing and homelessness issues, innovation in education and training, and obviously increasing our efforts to address conditions in Indigenous communities. So I'm just going to leave with you some action items for you to take a look at and for you to consider in the breakout rooms. Reviewing the principles of basic income provided on the BICN website, talking to your local politicians about some of the recommendations that have been made, and really working with our community partners and academics to create a research network to really look at rural trends and poverty specifically. Thank you.
Tracy, thank you again so very much. We definitely have a lot to work through in our breakout sessions from everyone who has presented so far. And I am glad to be able to turn it over to Jane Meadus from Edith, who we're so glad is able to join us today. And Jane, I'll invite you to mute and unmute and start your video and carry on the conversation that we started back with Edith and Laura about older adults.
Okay, so you can see me, right?
Yes, and we're so happy to.
Okay, so thank you very much for having me. Sorry about that. There were technical difficulties. I was here the whole time. And I'm glad I didn't do a PowerPoint, so I can sort of just sort of really focus on a few specific issues and kind of consolidate what I was going to say today, so we can get onto the Q&As, etc. So, when it comes to people in long-term care, there's sort of three main issues that I was going to talk about today. One is access to care. One is consent and capacity issues in long-term care, and the other is detention in long-term care. So, prior to COVID, these were all issues that we would see all the time in long-term care. People had issues getting access to proper care. People weren't, the homes were not getting informed consent from residents or their substitute decision makers, and people were being detained illegally. And, I'm a lawyer, I work in Ontario. So, my practice is in Ontario, and my experience is in Ontario, but most of this would fall in similar ways across the country. With respect to, care, we always had issues around people getting care, there not being enough staff, people not getting, being rushed through their care services. And of course, once the pandemic came, this became markedly worse. One of the reasons is in most places, caregivers, so family caregivers were asked to leave, were told to leave, and were barred from homes. And they were really propping up the system that was already very thin. And they found that, they lost this care, plus the staff themselves were getting sick or were quitting. And so we had a huge staffing issue. This is being dealt with in different ways across Canada. But it has taken a lot of advocacy by very very different groups to try to get more care. In Ontario, we have a promise of 4 hours per day per resident, but that's not until 25, 26. And that's not going to help today. And it's not going to help with getting staff today because there's no staff to get. That's the other problem, is we don't have enough staff. So moving forward, one of the things we have to do is to ensure that people are going into this as a profession, and that it's a profession that people want to work in. And right now it's a poorly paid profession. It's very difficult. It is quite problematic given COVID and people getting ill. So they're going to have to change that. With respect to consent and capacity issues, when people go into long-term care, they often lose their autonomy. The homes stop talking to them, and they will provide treatment to people without getting consent from capable people. And they will go to substitute decision makers, even though the person isn't capable, or they just, they don't bother getting consent at all. This increased during COVID. We do know that a large portion of people in long-term care do have mental capacity issues, although they are never or very rarely formally found to be incapable. They're almost never provided their rights, as certainly in Ontario, we have a right to challenge those findings of incapacity. And because of family members not being in the home and substitute decision makers not being provided with information, there was has been a absolute breakdown of any kind of obtaining of informed consent in many homes. And we heard throughout that people were not hearing anything about their loved ones in the home, despite the fact that they would be the substitute decision makers for them. There's a recent article published with respect to the increase in the amount of antipsychotics during COVID in long-term care homes. And that was because people were getting agitated. And my guess is that those homes were prescribing those medications without getting consent, and that's illegal. And so moving forward, this has always been a problem, and we need to train and make sure that the staff, including the physicians and the nurses, are getting informed consent, which is the law in every province in Canada. You may have different laws, but everywhere you have to get informed consent from a person or their substitute. And this really just isn't happening. And it went so far as to have the homes were making decisions to not, for example, send anyone to hospitals. We had homes that did that, not treating people. And there's been a real failure, not only in the consent issue, but really in the way that we're treating seniors. With respect to detention, pretty much across Canada and across much of the world, although certainly the Western world, people in long-term care have been detained in their homes since March. In Ontario, since about March 22nd, perhaps a little earlier, but it was officially March the 22nd, people were detained using a directive from the Chief Medical Officer of Health in long-term care and retirement homes. That was about 140,000 people who have been detained. Long-term care residents were detained until September. At that time, they were allowed out for short visits without any interference for about a month, and then that changed, and they now again have to get consent and are again being detained if they're in a orange, red, or gray home zone, plus of course if they're in lockdown because of an actual outbreak. But people who are not in outbreak are being detained. And the way that they're doing this is not in accordance with the law. It's not in accordance with the charter. Detention in long-term care has always been a problem. Ontario, as far as I know, is the only province that has any kind of detention law on the books, but it is not enacted. So people across, seniors across Canada are detained in a variety of different kind of care situations without any legal authority. It's entirely illegal. It's not charter proof. This is something that we, again, moving forward, we have to fight. And even with respect to the detention now, yes, we understand that people are, there is risk to people in long-term care. who are very susceptible to these diseases. It's absolutely true. And we have to make sure that people are safe. But I'm not sure that, detaining 140,000 people is the way to do it. And so I think we really have to think about, how are we treating seniors? Are we treating them differently in a way under the law? Because people in other sectors where there are detention orders, where there have been issues, they're being detained in using an order by the Chief Medical Officer of Health, and those orders are challengeable in Ontario. But for people in long-term care, it's just sort of a stroke of a pen and you're all detained, and there's no way of challenging that other than going to court, which is very expensive. So I think that we have to really look at the rights of seniors and ensuring that we're respecting those, and ensuring that, moving forward, that we're not simply being paternalistic and detaining people against their rights. And if you want to see what the residents think of these things, as you may know, the Ontario has a commission into long-term care into COVID, and the Ontario Association of Residence Councils did a submission to them, and you can hear the voices of the people and how they talk about being caged and feeling like caged animals for the last 8-9 months. And I think it's not a good reflection of society where you're detaining such a large number of people. We have to do better. So I'm going to stop there. Thank you.
Well, all I can say is, wow, Jane, thank you so much for opening up our thinking around this. I think these are a lot of things that we're not thinking about when we're supporting our diverse patient communities and what they might be going through. So I really thank you so much for joining us and being flexible with how to do that. I'm very grateful we got to hear your presentation.